Good afternoon and welcome to meeting number 4 of the Severe Mental Illness Task Force. As a reminder, we have a new meeting protocol in place for 2021 interim session. Remote access is allowed to all meetings for the interim session. Members were provided a Zoom link to access the meeting remotely. The meeting materials were put online earlier this week and made available for downloading. And at this time, I will ask the secretary to please call the members' roll. Remember, members, you need to indicate whether you are present, in person, or remote.
Senator Alvarado.
Present in the room.
Senator Berg. Senator Meredith.
Present in the room.
Representative Fleming. Representative Gibbons-Prunty.
Present in the room.
Representative Wilner.
Remotely in the 35th House District today.
All right, thank you. Co-Chair Kerr.
I'm present in the room.
Co-Chair Bentley.
Present in District 98.
Thank you.
We do have a quorum and so are duly authorized to do business. Next up, I would need, if you have perused the August 4th meeting materials, I would need a motion.
So moved.
Second.
And we have a motion from Senator Alvarado and a second from Representative Prunty. All those in favor say aye.
Aye.
All opposed? There is no opposition, I see. Before we begin with the presentations for members who are presenting remotely, please remember to mute your mics unless you are asking a question. If any member wants to ask a question, please let our staff know. Members participating remotely, please use the chat function available on your screen to notify the chair that you have a question. And we're going to begin today with Commissioner Wendy Morris. Commissioner Morris is the Commissioner for the Kentucky Department for Behavioral Health, Developmental, and Intellectual Disabilities. I believe that she is attending remotely. She is going to be discussing with us today Tim's Law. Commissioner Morris, are you there?
I am. Good afternoon. Thank you so much.
Good afternoon. Thank you. Please proceed.
Right. Yes, let me share my screen. All right. Can you all see my slides?
Yes. Thank you.
Terrific. All right. So again, thank you so much for the opportunity to be here today and talk to you a little bit about Tim's Law. While I never had an opportunity to meet Tim Morton, who this law is named for, I've known his mother, Faye Morton, for many years. I was a very active member of NAMI, the National Alliance for Mental Illness, for a number of years before I joined the cabinet. And she's a very strong advocate, and I know she's pleased that we're finally starting implementation of this important program. So Tim's Law, the provisions for Tim's Law are outlined in KRS 202A and were adopted, as you know, in the 2017 legislative session. It provides a mechanism for involuntary outpatient treatment known as AOT, or assisted outpatient treatment. And the implementation of those new provisions were contingent upon adequate funding. So our Department of Behavioral Health has been actively looking for funding since that was passed. We were we successfully applied for a competitive grant from SAMHSA, the Substance Abuse and Mental Health Services Administration, and were awarded $4 million last July for a 4-year grant. So that's $1 million a year for 4 years. The services were initiated in December of 2020 after a few months of planning and getting everything together. COVID, I will say, did slow us down a little bit, but we have since moved forward. We're required to serve 192 clients across 2 regions over those 4 years, and it's being implemented in 2 phases. We started in December in the Central State Hospital region, and that will run the entire duration of the grant. And then next year in 2022, we will start to provide services in the Western Kentucky Hospital region. This map just shows the locations of those regions. So you'll see in purple, That's our phase 1. And there's a star there that shows Central State Hospital. And they're served by 7 counties, Community Mental Health Center, and CommuniCare Community Mental Health Center. Next year in 2022, we'll start in the Western State Hospital region, which you see in green. 2 of the Community Mental Health Centers there, Pennyroyal and River Valley, will be participating. And then if we have adequate funding, we will also include 4 Rivers and Life Skills shown here in yellow before the end of this grant. So we're hopeful to reach all of those regions, and which is about geographically half the state. The grant objectives are pretty straightforward. We're looking to improve the outcomes for qualifying serious mental ill population in the regions that serve. We want to create a sustainable model for statewide implementation through collaboration, evaluation, and experience. We want to be able to demonstrate cost savings, that this will cost less than hospitalization, jail time, other adverse outcomes. Costs that are covered by the grant include some of the CMHC staff that were added, and some limited client support funds for things like transportation and personal needs. And they cover the cost of training, materials development and publishing of those materials, and evaluation of the program. Do note that the treatment providers are required to bill third-party payers for any qualifying services, so those services are not covered by the grant. This graphic shows all of our partners, our funded partners. So at the top is the cabinet, and then SAMHSA, again, that's our funder. That's where the grant money came from. In the middle, you'll see the 4 currently funded community mental health centers, CommuniCare, 7 counties, Pennyroyal, and River Valley. And then at the bottom is the Department of Public Advocacy. They're an important partner in this, and they developed our client rights statement, the brochures, to make sure that all of our participants know what their rights are. And then the UK College of Social Work, and they're providing evaluation and analysis in conjunction with SAMHSA and its designated technical assistant, the Treatment Advocacy Center. And that's both for local and national assessment of the effectiveness of our program. Some other important partners that are not on this slide include the Administrative Office of the Courts. I know that was one of the partners you asked about, and they really are a vital partner, both at the state and local judiciary levels, not just on this issue, but really all SMI issues. They develop the forms that are used for the current court processes. And just to note that judges are engaged at the client level, but also the local and state AOT team levels. So we do have representation on those teams. Other important partners include NAMI and other advocacy groups, law enforcement, specifically your crisis, your CIT trained officers, crisis intervention trained officers. This slide offers just a really brief overview of the treatment services and how the AOT is currently working. The evaluation itself is actually initiated in the state hospital, and I participated in part of the process when the language was written, and that wasn't the original intent, but how it's being rolled out is within the statute, and it's working very well because we know the people that are being referred do meet criteria and have recently had a crisis. So the psych hospital initiates the petition, which goes to the district judge. The judge determines if there's probable cause and will order an evaluation. Right now, those evaluations are all going through the community mental health centers. They also evaluate whether the person will meet criteria if they have the services available to assist this person. They submit that evaluation to the judge along with a treatment plan, and the judge can order up to 360 days of AOT. And then there are regular reviews during that order. The CMHC can order an array of services in that treatment plan: therapy, medication, housing support. They can attend to physical health care needs, vocational skills development, and they collaborate with law enforcement, family, other stakeholders, just a whole number of people. One thing that we've really picked up on really quickly with this project is that communication is key. Communication, 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 and we spend a lot of time on that, getting all the stakeholders talking to each other and making sure we're serving the best interest of the client and working towards good outcomes for them. The grant funds have allowed the hospital to strengthen their collaboration, both with the community mental health centers and those other partners, such as NAMI and the CIT trained officers. Some of the clients do get assertive community treatment or ACT services. I know we get asked about that a lot, but not everybody. It's pretty pervasive, but not everybody gets that. Each step of the court and treatment process are geared towards the individual's needs, and the judge the judge can adapt their role to be supportive, instructive, or an authoritarian. It really is what motivates each individual patient. And so we see that kind of shift. We're looking at a number of measures to determine if this is effective. On the individual level, we're looking at impact, not just participation, not do they show up, but what are the actual outcomes? So hospitalization days, jail days, homeless days, use of the emergency departments, Medicaid utilization. Are they satisfied with the service? Do they report substance use? And there's a, an assessment when they're first entered into the program, and then a 6-month reassessment to see how they're doing. Some of those same measures are being used to evaluate the program overall. So again, that would be psych hospital days, jail days, homelessness, emergency room utilization, Medicaid utilization. And then we're also working towards a cost benefit analysis. This is some client specific data. I know it's pretty small. Again, we only started in December, and this data is just for the first 6 or 7 months. So it goes through sometime in June. So you can see at the initial assessment, this shows 18 people who've been admitted. We've added another one since this data was formed for 19. There have been 20 referrals altogether, and only one of those folks didn't meet criteria, and that was very early on. Everybody has since really gotten in tune with what the criteria are. You can see about the most are male, so 13 of the 18. The majority fall between the ages of 26 and 54. 2/3 white, 1/3 Black. So there is a bit of disparity so far. The vast majority, 61%, have a diagnosis of schizophrenia, but we do have a variety of diagnoses. An initial assessment in the 30 days prior to coming into the program, there was an average of just under 23 days of hospitalization and 2 arrests, but with short stays. So only at the time that this data was collected, only 4 clients had come to the 6 months, and of note, nobody's dropped out. So we've got 4 who went all the way through, and there's some demographics here. And you'll know the number for race and ethnic adds up to 5. That's not a mistake. People can check more than one box. So that's what happened there. What's important here, I think, is the client status at the end. So you can see at that 6-month reassessment, not a single one of the clients had to be rehospitalized for psychiatric illness. So there were 0 days of hospitalization. All 4 successfully stayed out of the hospital. There was only 1 arrest, but please know that was for criminal activity that occurred prior to coming into the AOT program. So there were no new arrests, no jail that was affiliated or associated with anything that happened during those 6 months that they were part of the program. And all 4 respondents indicated that they had improved crisis and recovery support, that they were effectively dealing with their problems, that they always or usually were taking their medications, and staff believed in their recovery. So while it's not a lot of data, it's certainly, I would say, very promising data. Okay, again, just a little bit about AOT costs. So I talked a little bit about what it covers. I'm going to spend a minute on what it doesn't cover. So there are, of course, costs associated with the team in general, right? The staff, which will usually include a coordinator, a targeted case manager, peer support specialists, other clinicians and clinical support. Of course, there's operating costs like reporting and oversight, office space, supplies, human resources, fiscal support, training, and certification. Now, some of those costs, depending on what service area clients get, and the revenue we generate from those billable services will cover part of that. The piece that's a lot more difficult are the client support funds, and those are really more challenging to identify. That includes things like housing, which I know you hear a lot about, transportation, there's certain medications and medical services, and then just personal items that aren't necessarily covered. You specifically asked for future implementation recommendations. And as I said, we don't have a lot of data here in Kentucky, but we know from what we know from across the country is that AOT works. It works for a lot of people. And so we would recommend, albeit perhaps prematurely, that this should be expanded throughout the state to all our state hospital and CMHC's regions. But we would recommend that this be very incremental, that we take this at a pace where we can make sure it's done right, and that everybody has the support they need, we can provide the education and so on. This pilot project is specifically designed to help reveal a path forward as far as what resources are needed, what works best, those types of things. More generally, resources needed to expand it outside of the grant. This department we would want to be sure we were able to continue to provide oversight and technical assistance to assure fidelity, to assure that it's being done correctly, to monitor outcomes. The CMHCs would need resources for those components that aren't covered by Medicaid or other payers. And then, as I said, there's other stakeholders that are going to have costs and oversight burden, such as Administrative Office of the Courts, Department of Public Advocacy, the prosecutors, and others that I haven't listed here. I just wanted to make a note that you may hear from other stakeholders about possible suggestions to change some of the scheduling language in KRS. I'm not prepared to testify on those details, but I know that some of the timelines have proven a little bit difficult for some of our other stakeholders. This is just a link to our website, which gives a little bit more of the history and tells a little bit more about the program if folks want more information. And then, of course, I just wanted to thank you again for your time, and happy to answer any questions.
Thank you, Commissioner Morris. And we also have Deputy Commissioner Stephanie Craycraft with us today, and she's online as well to help answer any of the questions that you may have, members.
Yes, and I also have with me Tanya Dickinson, who's the grant administrator. So she's also available to answer questions.
Wonderful. We have Representative Bentley, who is the co-chair of the committee, with us remotely, and I'm not sure, but Representative Bentley, if you have any questions, please make us aware, okay? At this time,
I will on chat.
Thank you. At this time, I do have a question from Senator Meredith.
Thank you, Madam Chair, and thank you, Commissioner Morris, for your presentation. I know that the numbers are very limited, but it does appear that this program has a great deal of potential for us. I remember when we passed this legislation. Could you speak up a little bit? Sorry. I remember when we passed this legislation, a lot of excitement about it because of a dire need for it. And I'm glad to see that the initial indications are it's going to be a strong program for us, but a little bit bewildered, a little bit puzzled as to why there's so few people in this initial, would you call it a pilot program? But again, I would think that the universe for this is substantially larger than what this would indicate. And are there some barriers to implementation of this program? Do you have some players that really don't embrace it? Or is it a lack of resources? Or can you elaborate?
I would say none of the above.
Can you elaborate for me as to why there are so few when the potential is so great?
Well, I don't think we anticipated it to be hugely different than this. Again, we're looking to serve 192 people over 4 years. That's about 50 people a year. We only started in December, and we had a very slow start because of COVID, and we're only in one region. So I think that what you'll see is as the grant progresses, those numbers will pick up as we expand our geographic area. Right now, we're in the Central State region, which is located in Louisville. There happen to be a lot more resources there for people with SMI. So that could also be a contributing factor. We also, the TIMS law isn't the only way for people to have a commitment to outpatient services. Central State Hospital has been our one hospital that's historically been pretty good about using the voluntary outpatient commitment. So they actually discharge quite a few people on a voluntary commitment, which doesn't have some of the same provisions as TIMS law. There's not follow-up in the court and some of the other pieces to it. But we've seen that grow pretty significantly as part of, as this program has gone implemented, we've seen their numbers of voluntary outpatient commitments go up as well.
Well, that certainly is encouraging. Do you have a projected timetable as to when this may be, for want of a better term, fully implemented?
Well, the pilot goes until 2025. So obviously fully, as I said before, it's contingent on funding per the statute. So that would be, one factor, but we're learning a lot. And our data is pretty limited now, but every quarter we get a new data batch. So we'll have our next report will be in early November, and then there'll be another report in early February. And I expect that report in February to probably paint a lot clearer picture, and we should have a better idea about what the real cost will be. Again, for this region, I think Western State will want to do some comparisons between the regions because it's more rural. They have less services. Their history with using the voluntary outpatient commitments is not as strong. So I think it's going to look, the data will look a little different in each region.
Well, certainly we should see those cost savings that you kind of alluded to. And this will require commitment for ongoing funding, obviously, but would you care to project for every dollar that we put in this program, what the projected savings might be?
I don't think I'm prepared to do that today, but that is absolutely something we're working towards because we know that's important to the committee and a lot of other stakeholders. So that cost benefit analysis that we're asking UK to do should yield some of that information.
It is, and obviously our first interest is making sure that the patient gets the quality of service that they need in a timely manner. But as you can guess, while we're in the interim session, we're hearing from a lot of different people about the need for funding, particularly when it comes to health services. And I'm always interested in things that can generate a return on our investment. It looks like this potentially can. So I just want to make sure we're tracking that strongly, and that whatever programs are impacted by that, if there is a reduction, then we should make those adjustments accordingly. But appreciate your testimony. Appreciate the information. Thank you, Madam Chair.
Representative Gibbons-Prunty.
Thank you, Madam Chair. And thank you for your report. Actually, Senator Meredith asked my questions, but I just want to thank you, and I look forward to the work coming to the western part of the state, which I represent. So thank you.
Yes.
Thank you, Madam Chair.
Senator Alvarado.
Thank you, Commissioner. Thank you, Madam Chair. Thank you, Commissioner. I know we passed TIMS law, I think it was in 2017, if I'm not mistaken, right? That's the year that was, I remember that was, people were very excited. It had taken a while to get that bill across the finish line. So it's been in place for 4 years, or maybe a little bit, roughly 4 years. Maybe you covered this and I missed it. How many people total have utilized TIMS law to this point in the last 4 years in the state of Kentucky?
Not until we got funding was it really used. They had a similar, some semblance of a grant in the far eastern part of the state, mountain, but it really, well, I won't go into it, but it was different. But really, as far as the actual implementation of TIMS law, that just happened with this grant, to the best of my understanding.
So is the number zero?
Maybe one or two.
One or two people in 4 years. That was what I wanted to know. I remember seeing, I think it was in 2019, I saw an article saying that someone had applied for it in Jefferson County, and then I don't think I'd ever saw anything else as far as coverage. So that's what I was curious about, is how many people have actually utilized this, if it's just one or two. Thank you, Madam Chair.
Yeah. Mm-hmm.
Senator Alvarado, in our notes for today, there are some numbers there. I think you had to step out of the room, but there are some numbers. Page 9 of.
Thank you.
Okay, are there any more questions to come before Commissioner?
I I had a question. I put it in the chat, but
Oh, right. Yes, Representative Wilner, welcome. Please go
thank
with
you
your
very
question.
much. Thank you. So Commissioner Morris, congratulations on the SAMHSA grant. And I know we really couldn't get this up and running. You couldn't get this up and running until it was funded. And that was, basically written into the law that, as funding is available, I think was the terminology or something similar. So I guess, and I hear your recommendations for an incremental rollout. Do you feel that for the next 4 years, what you would like to see as an appropriate pace to roll this out and get it in Western Kentucky and Eastern Kentucky and across the state? Is that SAMHSA funding sufficient to keep up with the pace that you would like to see?
I think that's a really good question. And I think, again, we'll know more as the data rolls in. We have sufficient funding for what we're doing right now. We believe we are likely to have sufficient funding for the next year. It might be by the third year that we really there may be a need for additional funding. But that's, again, I'm happy to submit to the committee or share with whoever might have an interest in it, the data as it comes in quarterly, because I think that's going to be very telling. But right now it's very promising. I actually had a conversation with, I know many of you know Phil and Kelly Gunning last night, just to make sure they knew that I was testifying today and to share with them some of the initial results. They, like you, had lots of questions and are anxious for it to roll out. So we know there's lots of people watching this. And I think, it's important to us that it be done right, it be done with fidelity so that it really does provide outcomes. To me, the most striking thing about the data is that the clients are happy with the service. And that means that even though it's involuntary, they're getting something out of it. And I think that's why it's working, is because the approach that we're taking. And so I'm proud of the work that the team there at Central State Region and 7 counties are doing, and the justice system and communicator and everybody that's involved is really committed to making this work.
Thank you very much. And please add me to your list for the quarterly reports. I'll be very interested to see how this goes.
Thank you, ma'am.
I'd like to pause just a second and see if there are any more questions that people want to ask that are coming in virtually. Sometimes there's a little bit of communication lag when we're trying to do this. Well, if not, I really appreciate you being here today. I want to thank you for rolling this out, the implementation of it. I got here in 1999. I think in 1998, I went with a friend to a NAMI meeting at the old Eastern State Hospital. And of course, Faye Morton was one of the first people I met. So that would have been in 1998. And I appreciate Faye so much. She has been a constant advocate for this rollout. And her son, Tim, I was able to meet as well before he passed away. I too want to thank Phil and Kelly Gunning and those people of NAMI of Lexington, because they have been such great educational resources for me and for others. And thank you, Commissioner, for being here today.
My pleasure. Thank you again for inviting me.
Next on the agenda, we're going to hear, we hope, from Dr. Alan Brensel. He is the Clinical Director with the Kentucky Department for Behavioral Health, Developmental, and Intellectual Disabilities. He will be discussing severe mental illness populations and hospitalizations. Dr. Brensel, would you please identify yourself for the record, and you may begin.
Yes, good afternoon. Hopefully you can hear me.
Yes, and see you.
Excellent. Well, it's my pleasure to be here. As you mentioned, I'm Alan Brensel. I serve as the medical director, or sometimes known as the clinical director, for the Department of Behavioral Health, Developmental, and Intellectual Disabilities. So I work in Commissioner Morris's office. I've served in that role now for 11 years. I'm also a faculty member at the University of Kentucky. I'm a psychiatrist, adult and child, as well as a pediatrician. And so have worked in state government at some capacity now for 26 years. So happy to be here to talk to the committee. Appreciate the interest. I know it's a distinguished committee. Looking at the membership, you have a lot of direct experience in healthcare, hospital administration, pharmacy, and we know I live in your district. You've done a long history of advocacy around this population. So we're grateful. And so my goal is to talk to you today about our hospital. So I'm going to share my screen, I hope, given that technology doesn't desert us. Did that share? There we go. There's the share button.
It's up. Thank you.
Okay. Well, super. I don't see it, so I'm not sure why I can't see it, but we'll go from there. But again, are my slides advancing? For some reason, I can't see my slides.
I can see your slides, and I can see you, and I don't know if they're advancing because I've only seen the one slide so far.
All right. Let me, I may need some meeting controls. No. Are they advanced? If I hit this button, do they advance? Maybe I have to put the cursor over here. I think I got it. Sorry. Apologize. Now are they advancing?
Yes.
All right. So sometimes it's important to remember where you've been when you talk about hospitals. And so we're not doomed to repeat the past. But I think most of you are familiar that we have a long storied history in Kentucky of operating multiple state facilities. These are some pictures that I think are of historic interest. The one on the top right is Lakeland. That is the former Central State Hospital. For those of you who live in Louisville, that is now Tom Sawyer State Park primarily, and we built a replacement facility known as Central State Hospital. Eastern State is in Lexington, and that was the second oldest hospital in the United States operating to serve this population. It is now a beautiful BCTC campus, and I'll show you our new facility for Eastern State. But just out of historic interest, the one on the bottom right, that is the Feeble-Minded Institute of Kentucky. And that is a building that is part of the CHFS building here across from the cemetery and still in existence. And then Western State at the top is actually still open, and it has a gorgeous historic dome and is a fascinating building. But anyway, we're grateful that the legislature, in partnership with the executive branch, we worked together to provide funding for a replacement facility for Eastern State. And that happened in 2013. We've been incredibly grateful for those resources. And that hospital is operated in partnership with UK Healthcare and is intended to serve as a flagship hospital to help us address the needs of this population. Just very briefly, we do have 4 state hospitals and then an additional forensic hospital, which we won't discuss today. But we have Central State in Louisville, and this shows you the size that they are on a given basis. So Central State has on any given day an average of around 50 to 60 patients. Western State and Hopkinsville has around 119, 120. And then state owned and contracted, as I mentioned, UK Healthcare operates Eastern State and runs about 125 to 127. And then we have a partnership with ARH and Hazard, and their census in 3 regional programs now runs at about 77 individuals. So you can see this is a far cry from the day of those facilities I showed you before. Some of those facilities had over 2,000 individuals in each of them. And so there was a day prior to the 1960s where Kentucky had, 4,000 or 5,000 people that lived in our institutions. And so Kentucky was a leader in moving to de-institutionalization of individuals. In the 1960s, our community mental health movement was one of the premier movements in the United States. People came from all over the country to be part of that movement. And I think we could talk about, one of the things I wanted to possibly call this talk is living up to the promise of de-institutionalization. Because we did move a lot of people from hospitals, and we moved them because we had new tools, new treatments. Dr. Bentley knows a lot about how important psychotropic medications have been in relieving some of the symptoms. And we have been able to decrease the size and move people out of hospitals. And so people do not live in hospitals at this point. That is not something that's considered okay in terms of violating people's rights. So I think you all ask a little bit about our hospital budgets, and this is not my forte, but what you can see here is a 3-year trend of expenditures for each of the hospitals, other than ARH, which is funded differently in that because it is a distinct part of a regular med-surg hospital and eligible for Medicaid reimbursement. But you can see generally these are flatline numbers, but it does cost a lot of money to operate a hospital. Hospitals are expensive. They require licenses. They require clinical staff, fire doors, pharmacy. And so it is a lot of money on a small percentage of the SMI population, but a very important percentage. And so this is a little more detail about where those funds come from. There's a long history of something called the Imd Exclusion, which I assume you've heard about. But when Medicaid was created, it was not intended to fund state psychiatric hospitals or care for those folks in long-term care. And so it was restricted. Any facility that was predominantly serving those with mental illness was not eligible for Medicaid reimbursement. And so generally, we have funded those historically with state general funds appropriated by yourselves to serve those Kentuckians in need of this level of care. We do receive some federal funding through the disproportionate share provisions of Medicaid. We now do receive some small amount of funding from managed care organizations for people who stay a very short amount of time, and then some other payers there as well. And if you have questions about funding, Deputy Commissioner Craycraft is here, and at the end, she could answer questions. Who we serve in our hospitals, we primarily serve individuals who are on involuntary civil commitments. So we have very few voluntary patients. Those are served in our community hospitals, the private sector, and other facilities that can care for those. And so we primarily serve individuals who are involuntary committed under the statute we refer to as 202A. And that statute requires the person to have a mental illness, to be a danger to themselves or others. They cannot be cared for in a less restrictive environment, and they have to be able to benefit from hospitalization. And the thing about that law is it very clearly states that as soon as a person no longer meets those criteria, if they choose to be with discharge, we are required to discharge them by current law. And just a couple of other caveats about our hospitals. We do not operate at the state level directly facilities for substance use disorder as the primary diagnoses. So those are, again, cared for by our ever burgeoning and growing SUD treatment provider community, and we're grateful for our community providers for substance use. We do treat substance use disorder because about 25% of individuals with SMI as adults would also have a co-occurring substance use disorder. We do not serve individuals with intellectual disabilities if their need is just care for their intellectual disabilities. However, if they have a coexisting mental illness, they may be eligible to be served and may need mental health treatment just like any other citizen. And so we would serve those. And just a caveat, Kentucky does not operate as a state any mental hospital for children or adolescents. We got out of that business in the 1970s, and we again rely on our private community partners to provide hospital care for children. So I've got some slides, and I'll try to go quickly through these, but open to questions. This just is a 10-year trend of number of admissions on an annual basis by each of those facilities. And basically the number tells you the totals. And so you can see that we serve about 2,000 people, 2,100 in 2011, and we serve about 1,700 in 2021. And that again is total number, not at any given time, but served over the year. That is a substantial decrease. We can talk about why that might be, but again, not the trend we saw in the decrease from the 60s and pre-1960s. But we do serve about now. I think you all have heard testimony, but we estimate there's about 82,000 individuals with SMI in Kentucky, and so you can see hospitals serve only a small proportion of those individuals who might be deemed as SMI, but we do serve about 1,700. This is that average daily census that I mentioned in that slide. Some of our hospitals, Central State really averages about 50 individuals. Eastern and Western are closer to 110, 120, but only about 83 per facility on any given day in 2021. These are the lengths to stay, and that's very important to think about. Average length of stay, that's that green line in the middle, is about 16 days. And that is a far cry from the days when you crossed the threshold and you never left and you were basically hospitalized for life. So we basically operate acute psychiatric facilities for stabilization of individuals with SMI who require hospitalization. We do have some outliers that stay 90, 365 days, we have many folks who stay 3 to 7 days and are returned to care in the community. There's Western and Central tend to have a little bit longer length of stays. ARH tends to have the shortest length of stay. This is the diagnosis of those we serve. You look at the definitions. I think you'll all have talked about SMI, but typically we're talking about individuals with thought disorders like schizophrenia, which is about 29% of them. And then affective or mood disorders, which include bipolar, is about another 27%. And then a comorbid, about 23% might have a substance use disorder. But it's primarily severe mood disorders and severe schizophrenia and other thought disorders. One of the quality indicators we look at for our facilities is readmission rate. And so this shows you the readmission rates at 30 days, 90 days, and 180 days. And basically it goes up progressively because the longer time, the more likelihood of readmission. And it trends this over time. And so basically, if you look at 2021, about 10 or 11% came back within 30 days. And that does not make us happy. That is not what we like to see. And we'll talk about some of the factors how that might be related. But it goes on up to as high as 25% within a year, within 180 days return. And it shows you the challenges we have, because many will be stable, leave the hospital, go to the community, perhaps not stay in treatment or deteriorate due to other variables. And so what we don't like to see is what we call the revolving door phenomenon, right? Where folks are admitted, released to the community, returned to the hospital. That's not good for anybody. And it's not good for the course of the illness, because we do know that individuals who have frequent exacerbations may be more refractory to restabilization and not respond as well to subsequent episodes. This is we track to see what percentage of individuals leave our hospitals, get seen in an outpatient setting. And I will have to say, predominantly these folks are served by our community mental health centers. And so we can contractually require them to see our hospital discharges within 14 days of release. And so they will schedule them, and about 50% of them will show up for any follow-up within 14 days. That orange bar in 2021 for Central State there is a data issue. The number of admissions is not accurate. Therefore, the number of follow-ups was not accurate, and I could not get that corrected. But Central is about the same as the others throughout all the previous years. And I would anticipate that it's a disappointing number and something to talk about what we can do. This is just to remind you that the community mental health centers are our key entities for that follow-up. And each of our hospitals has a catchment area where they admit patients from that specific region. Therefore, they develop relationships with those community mental health centers. And often they are their patients, and so they know them before the admission. But sometimes the first time we see somebody is when they get hospitalized. Therefore, they're a new patient to that community mental health center. So one of the things we've done to try to increase that 50% is to have our community mental health staff come to the hospital, or in the days of COVID and the days of challenges with transportation, use telehealth to physically meet that person prior to discharge so that they have a face and a name and know who they might see after they leave the hospital. That is called a warm handoff in our terminology. Those other tools we've talked about and down on the list are the agreed order, the voluntary outpatient commitment, and Tim's law for some of those individuals. But the vast preponderance of our folks who leave, we believe that voluntary care and voluntary follow-up are the most effective long-term. It's just a limited number of those who don't have the insight to know that and are willing. But we do supply discharge medications to everybody who leaves the state hospital. We give everybody 30 days of medications. Therefore, it should not be that they don't have medications, can't get to a pharmacy, can't get their pre-auth done, can't get it filled. But after 30 days, then they do need to We also are encouraging the use, and I know Dr. Bentley is very interested in long-acting injectables. We find that long-acting injectables, initiating those in the hospitals is a very effective tool, but they still have to show up for their next injection. And so we can't solve that necessarily just in the hospital setting. That has to be part of our community access and follow-up. Transportation is a big barrier. That's why we often drive people from the hospital to their first appointment on the day of discharge in some of our hospitals, particularly Central State. That ensures they at least make that first appointment. They get enrolled in follow-up care. They meet their provider. They know who they're going to see. They know the drill. They know the door to go through. We've talked about a little, I think you all have talked about assertive community treatments, and that is a really key tool. We don't need to be sitting in our office waiting for these folks to come to us. We need to be going out and finding them and engaging them where they are and ensuring they have the resources to get the follow-up care. And so we do fund assertive community treatment teams in each of our CMHC regions. And we'll talk about the challenges we have in establishing those and maintaining those. But those are teams where there would be at least one or two folks who would be high frequency, low intensity touches. And then they would ensure the folks come in for their follow-ups for medication and therapy and overcome some of the barriers associated with transportation. Most of our folks are Medicaid eligible. And so they have our managed care companies, all 6 should have care coordination for the folks who are eligible. And typically those are folks who are hospitalized. And so we invite the MCOs to attend our discharge planning meetings, particularly for complicated patients who've had frequent admissions, so that they can engage them and utilize their core care coordination efforts to get folks through any hurdles that might be there. Mentioned Tim's Law is for a small number will be a valuable tool for those who, again, at discharge don't have the insight or part of their pathology is resistance to follow up. And then making sure we get folks who really need substance use treatment to substance use treatment, which is really much, much more available now, because if they relapse in their substance use, then their mental health condition likely deteriorates as well. So some of the challenges, so as I mentioned, most folks are in our hospitals against their will. And so very often they don't want to be there, and therefore they don't want to go to follow-up. So that's one of the challenges we face when you serve a population that part of their pathology is to be paranoid about the medicines, paranoid about what people are trying to do with them. They haven't recovered to the degree to have enough insight to know they need their medications and need the support. And so that's part of what we face. Transportation is a huge barrier. I think that's been alluded to by several of folks who've testified, and I know it's an interest to the committee. But I will tell you, one of the major challenges, and where I sit, I advocate for consumers. I get direct calls from families and consumers, if not daily, weekly. And the number one barrier that I find that makes it hard is unstable housing. Folks, we can create a robust continuum of care, but if a person does not have a place to lay their head at night, it is almost impossible to serve them and use our evidence-based interventions to stabilize them. And so I do applaud the efforts, and I think you're going to hear from some of my colleagues in Medicaid about how do we use resources to stably house folks and provide a residential benefit, because it's the saddest conversation I have is that folks have burnt all their bridges, their families are unable to care for them, or they don't have contact with their families. They don't have stable housing. And I'm going to show you a percentage of folks who we discharge who might even go to shelters, which again are not trauma-friendly settings. It's where you have difficulties keeping people stable. And then I mentioned ACT teams, and ACT teams right now, one of the things we're struggling with is fully staffing them, and then deploying them across rural regions is expensive. It requires moving our therapists around, which is a good thing, but actual transportation costs may not be covered. It is a covered service in our state Medicaid plan. We're very grateful for that. It's not a covered service if you have private insurance. So one of the challenges we have is many people with SMI present while they're covered with private insurance. It's not until their condition deteriorates or they lose their employment because of their illness that they then become Medicaid eligible. We can't let people deteriorate that far before they have access to these services. And so this is what I promised you about where do people go when they leave our hospitals? About 2/3 of them go home, and home is either their own home or home with family. And but about 8% go to a mission setting, which is our database terminology for emergency shelter, really. And that's a number we're all embarrassed about and all very upset about. And we work diligently to avoid that. But if people choose to leave, and if we can't legally hold them, we do facilitate them going at least to a setting where they'll have a roof over their head. Personal care homes are another topic for us, but at this point, we have concerns about many of those as well. We're under some federal scrutiny around the fact that might be considered inappropriately segregating and congregating people with disabilities, and whether they folks would choose to live there or whether they're being offered the chance to live in the community. But we do still discharge about 6% of our folks. Most of them have come from a personal care home and they return. And then you see jails about 4%. So folks who have active charges upon discharge might go back to jail. Now, many times that might be dismissed, or if mental health court is an option, then that might be they might be able to be diverted from jail through a mental health court. And some go on to other settings. And if you had any questions, we could talk about that. And so thinking, from my seat, what I want you to know is, hospitals are an important part of the continuum. They're very, very expensive, and they serve a very, very small percentage of individuals with SMI, an important one. But what we now know about the neurobiology of SMI and the conditions that cause it is we can prevent this course of chronicity and frequent relapse and remitting course by early intervention. And, if you're all interested, we could have, someone come talk to you about what we call identifying ultra high risk individuals, pre-psychotic break, or high risk individuals, we are developing programs for first episode psychosis in each of our community mental health centers. And SAMHSA now requires us to devote a certain percentage of our block grant to develop programs for first episode, because we believe if we can stabilize that person, prevent them from having, again, multiple acute exacerbations, we can change the trajectory of their life and the course of their illness to prevent the level of disability that we see in some individuals. So early identification, I know you hear that all the time, prevention is the best medicine, early intervention, but the evidence for particularly schizophrenia is very clear that programs, and as I mentioned, one of the problems is people present, again, while they're in universities or while they're in working and have private insurance, and our private insurance providers do not offer some of these services like assertive community treatment and do not offer the level of intent. Families sometimes get a diagnosis and a handshake and a good luck. And those are the calls I get. What do I do now? And so I do want you to think about early intervention, identifying those at risk, intervening early, and enforcing parity is very important in that regard. And then, we need funding to create a recovery-focused system of care. We need new payment models to make our CMHCs viable. Some examples of those include the CCBHCs, which I think you've heard about or may hear about from our colleagues. That's a funding model that will help us provide services to all comers and not just on an individual fee-for-service basis. So we can do some of the kinds of things that keep people out of the hospital and engage them so that their adherence is better. And diverting people from the justice system, heard you all mention that. Mental health courts are a very important part of this. And then, as I said, preventing the decline. Once a person disenrolls from school because of a serious mental illness, their likelihood of going back are low. So we need to keep them in school. We need to get them employed. They need purposeful activity and purposeful employment. And then I think I'll end with this recommendation for looking at housing. We do not have residential mental health treatment facilities for people with serious and persistent mental illness in Kentucky. And the thought there is that generally we can serve them outpatient with intensive services, but they have to have a place to lay their head where we can wrap the services around them. So that's what I have to add, and I'm happy to take any questions.
Thank you, Doctor. We have with us, who has joined us, Representative Moser, Chairman Moser, and I believe she has a question.
Yes, I do. Thank you very much, Madam Chair. And thank you, Dr. Brensel, for this presentation. I've worked a long time to see some of the this conversation happen. And so I'm very happy to be able to join the task force today to kind of hear this. I have a question about the Assertive or the ACT team. Who are the individuals who make up this ACT team? What exactly are they tasked with? I think I'm very intrigued by this follow-up model. We started a quick response team in Northern Kentucky dealing with addiction. And it's my understanding that they now serve some individuals who suffer with severe mental illness. Is this, who's the ACT team made up of? And I have a follow-up to that, I think.
So it's an evidence-based model, and there's large ACT teams that have as many as 10 provider members, and then there are smaller ones. But typically, they are made up of a targeted case manager, a peer support specialist, often in a person who is called a community support associate, who might spend time in the community with them. So similar to a community health worker, but a community support associate. They would have a physician as part of the team. In Kentucky, I don't think the physician service is bundled into the ACT rate, but a physician is separate, but a key member of the team. And even for folks not on medicine, it's important that they meet with a physician on a regular basis to talk to that individual about when would you accept medicine, what are the benefits of medication. And so typically it's 4 or 5 people, and then the other, might be an LCSW, another therapist that would meet with them on an individual basis. So a therapist, case manager, peer support specialist, physician, and community support associates are kind of the bare minimum for an ACT team.
Okay. And if I may, Madam Chair, a follow-up.
Yes.
Thank you. So the ACT team, how are they activated? Not to use any sort of bad pun.
So they accept referrals, like any community mental health center. And so they have a team that would review that person's referral and determine whether or not they could serve them. And, I do say that we have them in all of our 14 centers, but I'll be the first to say that not all counties and all of our 14 community mental health centers have access to ACT teams. So it might depend on the distance from where the ACT team is located. We do have struggles, if folks are determined to be potentially violent or assaultive, then the ACT teams may have a concern about serving them in the community. And so some states have forensic ACT teams, which are staffed a little differently, where they can handle more challenging individuals. Our Tim's Law pilot really is looking at what does it take to manage. And so the Tim's Law, so right now, if you're on an ACT team, you would leave the ACT team if you're in the Tim's Law pilot, and you would be on a Tim's Law team on the grant. And so that's what we're discovering there. What does that team need to consist of? How often does the contact need to be? What's required to make the reports to the court, and the extra work required? But the challenges right now are recruiting staff, maintaining them. This is difficult work. These are individuals often hard to find, and sometimes they don't open the door, and sometimes we have to engage them in creative ways. Sometimes they're homeless, living on the street, and we are trying to serve people who might be living, marginally. And so staffing and recruiting and retention, and the reimbursement rate is significant, but, there are challenges in that rate covering all of the additional non-direct service kinds of coordination And then meeting criteria for medical necessity and things like that are often some extra burden for administrative folks. But it is a key model for keeping these folks out of the hospital and keeping their illness managed.
We have
thank you for that. If I could see the funding model, I would be very interested in just trying to see how that really breaks down on a state level, and if I don't know if Medicaid is involved, but I don't want to monopolize the time here. I have a million questions, so maybe I can talk to you offline.
Yeah, sure, we'd be happy to, because we've looked at other state models. Some states fund it directly, some states fund it on a fee-for-service basis, but we would be happy to talk with you about that.
Thank you.
Thank you, Representative Moser. I have about 4 more questions here, and if we have the time, we can come back to you. At this time, Representative Ken Fleming has some questions, and welcome. I know that you were here just right after we took roll call.
That's right. Thanks. I appreciate recording me
you
for
are
being
present.
here. Thanks. I have several questions, Doctor, but hopefully they'll be short answers. Just as a backdrop, I've been running a mental health center for about 6 years, but my background is really in business in terms of owning and running some businesses and so forth. So that's my backdrop. So when I ask these questions, you might know where I'm coming from. I want to try to get some clarifications on your slides, particularly number 4 and 5. When you compare when you look at the number of the budget on a per patient basis, what I can tell is like 305 patients for $116 million, which is about $380,000 per patient. Is that a correct interpretation of this?
So I'm trying to get back to that slide, and I'm not sure. So you're taking the total of the 116 million and dividing by, we had to divide by the total number of individuals.
That's right. And that's 305 based on slide 4, compared to slide 5.
So that's the average daily census, not the number served throughout the year. So in other words, we might have 50 people there today, but we might have another 25 there the next day. So the slide that shows you the number of admissions, I think that's the number, slide 8. The number of admissions is 1,700.
But I'm taking the 59 as your average number of patients.
But the expenditure is for the whole year.
That's right. But you have an average 59 or so that I can tell for Central State. Is that throughout the year, or is that
that's a snapshot of that's average daily census. So on Tuesday of this week we had 50.
Okay,
but we might have served 200 people this week, and so for the whole year, if you look at slide 8, that shows you the number of people served annually. And so Central State on that slide looks like they had about 1,200 or so people they served that year. So you would divide that by the.
Okay.
But you're right. The per diem, I mean, we can get back to you about what our per diem rate is. And our per diem is significant. And the problem is it's even when a hospital gets smaller, we can't cut costs. So we have some variable cost. Yeah. We can get rid of and downsize our staff, but our facility cost, our overall cost do not go down when the facilities get small.
I'm sure you got a lot of fixed costs, and I understand that. And I want to go back what you said a second ago in terms of admissions and readmissions. If I'm looking at page 8, your admissions for 2021 is 1,700, and your readmissions on slides 12 is 13. So that's a pretty, of those, is that a subset, the 1,200 to the 1,700? So you're admitting a whole lot more than you're taking in for new folks?
So the 1,700, I'm sorry, is an average of all the hospitals. So that 1,700 isn't a total.
Okay, but my point is, and I'm trying to get down to treatment and the care that you're providing, which I'm not doubting, but I'm just trying to get a better understanding. So if you're taking, it doesn't matter if the average is whatever, then you're taking in the average is X, and then your readmission is Y, but your Y is very close to X, then I'm trying to figure out what's going on in terms of, and you said that there's a lot of readmissions from folks that they don't, because one reason is because you're housing. I understand that. So that's one particular challenge and problem that we got to address and help you out with. Mm-hmm. You understand where I'm coming from?
I do, but I apologize, and we'll try to get you some clarity on the numbers. But the number for readmissions, if you look at slide 12, that's on the left axis, that's the percent of the individuals admitted total that return. So it's 10%. So we have about a 10% readmission rate across all of our hospitals. And that's not unlike any of the national averages. Some of our hospitals are lower than the national average. Some are slightly higher, but we readmit about 10% of all of the folks we discharge within 30 days. And then within 90 days, we readmit. If you look at that number is 986, that's about close to 20% get readmitted. And what's interesting is we look a lot at, so who's getting readmitted? Because I used to think, well, the reason we readmit people is because we don't keep them long enough, right? So if we discharge someone too fast, they return. Well, what's really fascinating is the people that are more likely to be readmitted are the people who stayed longer. And that's because it's a marker of severity of illness. And so the challenges in my mind are that the folks that are most complicated and we keep the longest, we don't have perhaps the right level of support for them in the community to keep them from coming back. Because often they leave, they're stabilized, but they don't stay stabilized once they return to the community. And that's why Tim's Law was an important tool that can help us, but it's still very difficult to force people to take medications who do not want it. We are not able to break into someone's house with a white jacket on and a syringe and give them an injection against their will. That is just not something that even Tim's Law lets us do. Now we can use the judge, we can use the possibility of going back to the hospital. We can use a lot of tools, but again, our 10% readmission rate within 30 days is not good, not proud of it, but unfortunately kind of around the national average.
Okay. Slide 15, do you get compensated for transportation? Do you get compensated for transporting the patient after discharge?
No, that would be in our facility budget. We would just use our facility resources.
Okay. Okay. And then one last question, the parity. Could you give me a 30 seconds observation on parity when it comes to mental health versus the physical size of health in terms of trying to get that more in a stronger position for having parity for mental health?
I mean, I think Kentucky, again, was progressive and early in adopting parity requirements. I think the challenge has been enforcing them. And I sit on the Eating Disorder Council, and today that was the discussion there, is they don't believe there's parity for eating disorder services. They believe the medical necessity criteria are too rigidly interpreted. If you have cancer, you get lots of follow-up, and you get a nutritionist, and you get mental health services for but if you have a mental illness, you often get 3 sessions, and then you don't get any additional services. You're not allowed occupational therapy. You're not allowed the other kinds of support. So I really think the issue, and I know this is being addressed on a federal level, is enforcement. And we work with the Department of Insurance, and I know they do actively investigate, but we just have to understand that we need to fund mental illness as an illness, and like other chronic illnesses like diabetes and cancer, and offer the whole array of services.
Thank you, Doctor, and thank you, Representative Fleming. I've got 3 or 4 more questions.
Thanks for the liberty to do that.
Senator Alvarado.
Thank you, Madam Chair, and Dr. Brensel, good to see you. I guess in your presentation, just to clarify, based on the recent questions, I think there's on that average, you get about 6,800 or so admissions per year at all 4 hospitals combined. And so if you compare that to the slide 12, it makes more sense when you compare the percentages from that. On mental health parity also, if you have anybody, we passed that law, and if people are, there's been some fines levied against some of our insurance companies that haven't followed that. If you have people that aren't doing that, please notify us, the executive branch. We need to hold our insurance companies accountable. The one thing I wanted to just maybe you can comment on, I'm involved a lot in long-term care, obviously, and I do a lot of nursing home work. When I see the amount of discharges, 0.5%, boy, I can tell you it doesn't feel like that in long-term care. I could honestly say I know this is only from state-operated facilities, and there's people that go to private hospitals as well. I would easily have, double that just in my small census of patients that I see every month. I'd say at least 15 to 20% of what I have right now in nursing homes are people with schizophrenia and a lot of not just dementia-related, but true schizophrenia and severe mental illness that I manage. And I'm not a psychiatrist. I'm not an expert. I do the best that I can. I know that Eastern State used to have a long-term care wing that got removed, so I was hoping you could comment on that, if there's any hope of having that come back. And then also, I know in your slide about talking about how to efforts to improve outpatient follow-up, if there's been any consideration from our state hospitals to provide that for private nursing homes, because we have psych teams that come in, they don't come in very often, even if something could be done through telehealth, because the people that we have coming in are not physicians a lot of the times to provide that care, and I probably have more expertise than some of them who offer recommendations and don't really help our patients. And so I get a sense that there's a churn from some of those folks rather than actually providing them care. If I could have a psychiatrist lay eyes on them, and maybe if you could comment on Eastern State's long-term care wing and that as an outpatient follow-up.
So, I think you mentioned the issue of the lack of, some people have said it's psychiatrists right now is like a unicorn. They're awfully hard to find. And so I think we have a serious workforce issue, and that makes it a challenge. As you mentioned, 65% of all psychotropics are prescribed by primary care physicians. So training for them is very important. I hope you'll consider utilizing expertise at the University of Kentucky and University of Louisville. I graduated from, you did med peds, I did peds psych. So I did primary care, but also decided to specialize in behavioral health. UK is now starting a med psych residency. I'm not sure if you're aware of that, but we have to train a workforce, and we have to offer those in primary care access to training, because they are going to be pressed into managing, just like you are, it sounds like, for the folks you care for in long-term care. I mean, I'd love to say that we had enough staff to be able to sort of open and provide expertise. For our folks with intellectual disabilities, we have created ICF clinics where we take our expertise from our staff facility, our staff who work in our facility, and then offer it to folks after they leave. The challenge with that model is that we are right now understaffed in our hospitals. We're having to use locum tenens physicians. We're constantly recruiting and losing. And so it would require more stability in our staff, but it's certainly a thought. And then UK is engaged in some really innovative models, which we think might help. Is they're going to partner with Community Mental Health Center there, New Vista, where maybe they'll provide the ACT team members like the therapist and the case manager, and then where UK might provide the psychiatrist and the medical support. And so they may use one of those personal care homes to do that and create a model where we can serve people who are discharged in a more coordinated way, or use it for crisis to avoid hospitalizations. But I think you're absolutely right. We've got to grow workforce. We didn't have the sustainable funding to continue to operate that personal care home. We were concerned about COVID and needing it. If we had to move anyone from another facility, we wanted to have some space available. So we're looking at sort of repurposing one of those as an empath crisis center. And also UK is looking at doing some outpatient collaboration with New Vista's ACT team and doing integrated care. We didn't even get to talk about integration of primary and behavioral health, because these folks, as you all I think have heard, are dying 11 years earlier. They have chronic unmet medical needs. Sometimes they get to primary care. And so, you're the ones pressed into renewing their meds. But I think that's the issue for us is growing and utilizing our psychiatry staff in the most effective way, like using telehealth, like having them collaborate as a member of the team and provide. But we could certainly look at how do we extend the expertise within our hospitals to the community as we get through our own staffing crisis.
Representative Gibbons-Prunty.
Thank you, Madam Chair. And thank you, Dr. Brensel. On slide 7, I felt like you were implying maybe a change because you said in current statute they have to be released if they don't meet the criteria. I just wonder, were you implying some sort of change in statute, and what would that be?
No, I just wanted you to be aware, that we don't have the legal ability to keep people beyond when they meet this criteria. And this is not new criteria. This is Kentucky's criteria. It's similar to other states, and it's about civil liberties, right? And the whole societal question is, do you have a right to not take your medicine for your high blood pressure, or a right to not take your medicine, a right to drink alcohol to the point where your liver is failing? And so the question is, do you have a right to have untreated mental illness? We do step in as society. We do use our laws to try to care for folks who aren't able to care for themselves. But our statutes sort of clearly specify, how long we can keep people. And there are interpretation issues, because you notice this doesn't say imminent danger to self or others. And the question is, what's danger, and how is danger meaning that I'll freeze? So, we get more admissions when the temperature is minus 20, because if you're not able to come in out of the cold, you're a danger to yourself. Well, you might not, that same criterion might not be met other times of the year, unfortunately. And so but we have court in every one of our facilities. Judges are the ones making these decisions. Our teams testify. They have a public defender whose job it is to represent that individual's interest. And so there are cases where a judge does not uphold our recommendation and discharges the person.
Thank you. Thank you, Madam Chair.
Yes, and Doctor, thank you so much for being here today. Thank you for your thoroughness, and please email Representative Bentley or me with questions or resources or people that you would like to hear from in the coming days. Thank you. Next on the agenda, we have Leslie Hoffman with us. She is the Chief Behavioral Health Officer for the Kentucky Department of Medicaid Services. And we also have Deputy Commissioner Veronica Judy Cecil with us today. They are going to be discussing our mental health waiver. Hope you're there.
Hi, Madam Chair. This is Veronica Cecil with Kentucky Medicaid.
Great. I see two of you here, and if you would proceed with your presentation.
Absolutely. Leslie is going to do the primary presentation. So go ahead, Leslie.
Making sure I've got it up correctly. If everybody can see my screen.
Yes, we can, and you as well.
Okay, and happy to be here. Thank you for having me. So I'll just go ahead and get started. We were asked today just to give you an update about any SMI waiver options or initiatives that we have going here in Kentucky, and I will try to keep this high level. Just a second, let me get my screen. There we go. Okay, so actually in 2020, we started a really intense deep dive related to research on SMI and SED waivers and the different authorities that we might be able to take a look at for Kentucky ourselves. So we looked at 1915Cs, 1915Is, and also 1115 waivers. We also looked at what other states were doing related to these particular waivers that I have listed on the screen. We, in this year, on 9/1, we hired a dedicated staff. So we have a dedicated staff now for the SMI SED initiatives. We've completed lots of training and collaboration, and I'll talk a little bit more about the collaboration later on a federal level related to SMI and SED and what options we have for here in Kentucky. We have had ongoing conversations with CMS, the Center for Medicare and Medicaid Services. Currently right now, and I just spoke to them this morning, CMS is currently recommending that we would add an SMI SED waiver under the same authority as our approved SUD 1115 waiver that we have. And we also, some other things that we did was last year, at the end of last year, Robert Wood Johnson Foundation, as well as the State Health and Values Strategies group, which we call SHIVs, reached out to us for technical assistance. We did apply for the technical assistance and we were approved. It's a 6-week technical assistance that they can offer to us for free. And we asked at that time to hold off until we could, of course, get our staff up and going, which was just September this month of this year. So we have our next kickoff with SHIVs on October the 20th next month. So although we don't have an SMI SED waiver right now, we've had many initiatives that we are working on or getting started in the next couple of months or year, and they all include SMI SED. So I thought I would just share a couple of those with you. And this may be more than that you want to hear today. So if you have any questions later, you can just reach back out to me and I can help with those. As you heard Dr. Brensel speak, we have one initiative that we're working on that will roll out January of 2022. It is the Certified Community Behavioral Health Clinic, and that's what we call the CCBHC. This is a clinic that will be certified, and it will provide a comprehensive array of services that would include mental health, substance use disorder, and physical health services. And as you heard Dr. Brensel also speak, that we need that integrated care piece. So this is a really good opportunity for the state of Kentucky to really pull together and have that integrated care for individuals and the members out in the community. So this would be available to any individual in need, and it's not just limited to SMI or SED. As you can see, it's for long-term chronic addiction, mild or moderate mental illness, substance use disorders, and complex health profiles. So we're hoping to catch some of those folks that have the dual diagnosis and have some chronic health conditions as well. Also, it's care for individuals regardless of their ability to pay. And in this bullet, I wanted you to notice that there is a whole component to the CCBHC that addresses active duty military and veterans. So it's very important. So other initiatives that we have going on is our Cms Housing Collaborative. And we've been participating over 9 months in a housing collaborative on a federal level, which started out as a housing initiative related to substance use disorder. But Kentucky soon saw that we needed to talk more about, not just about SUD, but we needed to talk about SMI and SED. We've also talked about just the homeless population in general. So this is a really good group collaborative that we have here in Kentucky. We have Kentucky Housing Authority is on, Department of Behavioral Health is also part of that group. Opioid crisis response groups are on. So we're taking a look across the board, and that's still ongoing. We're meeting on a regular basis. Our collaborative is over, but the state of Kentucky, CHFS, decided to continue to meet because we do know that there is a great need for housing assistance here in Kentucky. So our mobile crisis planning grant was an initiative that DMS worked in collaboration with our sister agency, DBHDID. Recently, we applied for this grant through the American Rescue Act plan, which you may hear the word ARPA come up. And lo and behold, we're so excited. Just this last Saturday morning, I received an email that we won, we were awarded the planning grant. So very excited about that. And this was a really good collaboration between DMS and DBH to kind of pull all of our different funding streams and our different programs together to kind of enhance or expand the crisis services. And we would like to see our vision is to see this comprehensive behavioral health crisis model for Kentucky. So very excited. And I can tell you all more about that later. I just wanted to share that with you. Another thing that I wanted to mention is, as you may be aware, in our HCBS enhanced FMAP request recently that the Department of Medicaid sent in to CMS, we also embedded crisis dollars that could be used across the board, which would include SMI and SED. And we also asked for a feasibility study to be able for SMI SED, and also to take a look at the housing and employment supports. So those are embedded in the HCBS enhanced FMAP that you may hear in other meetings. So we had that embedded. We did check with CMS today. We're hoping to have an answer back on those requests maybe next week. That's pretty much it. I wanted everyone to know that although we don't have that waiver in Kentucky right now, we are working diligently on other programs that include the SMI SED populations. And you will hear us say SMI SED. We're not just limiting it to just SMI we're including both of those populations to include the children's programs as well. So do you have any questions?
Senator Alvarado has a question.
Thank you, Madam Chair. And of course, these grants are of interest. I mean, I'm working on several task forces this summer. One of them is an SJR 59 looking at substance use disorder and people for housing, which is another obviously important. A lot of those folks have comorbid conditions of mental illness. And we're being alerted of different small pots of money here and there that could help for that. We're looking at developing pilot projects for SUD population. Do we know how big these grants are? How much money are we talking about as far as some of these? I mean, obviously we're looking at, you mentioned the CCBHC kind of clinics and using it there in this new mobile crisis planning grant, which is great news. How much are we looking at as far as total grant money and all these programs combined?
So the CCBHC is actually a demonstration that will allow Kentucky to, there was a 2016 application that included 4 of our CMHCs. And so this one will be a little bit different. It will be to provide those services within a very intensive array, more so than normal. It just happens to be the 4 CMHCs that are providing those services, but they will be certified to provide a higher array of services, if that makes sense, and more of that integrated care. So the CMHCs that will be CCBHCs going forward will be able to receive payment for those enhanced services. Does that make sense? Does that help?
Yeah, and then just in terms of the mobile crisis planning grant you mentioned was just approved. Do we have any dollar amounts around a lot of those?
Yeah, our estimated award is about $800,000. The maximum allowed award was $1 million up to 20 states. So I think we're right at $800,000 for the planning grant.
Representative Wilner, your question for our presenter right now, and then I think you also have a question for Dr. Brensel if he's still on.
I do. Thank you so much, Madam Chair. Quick question for you, Leslie. Thank you for the presentation. Can you just help me understand what services would be in the waiver for SMI versus services in the SED waiver?
So it's really about the population. It would be the adult population over 18 versus the younger children that are under 18. It's just the populations. But really one of the things that we've been trying to focus on for the 11-15, of course, like Dr. Brinsle said, is residential is a big issue. Employment's a big issue. The integrated care is a big deal. I was trying to think of some other things, and the care coordination in general. So like for example, the CCBHC that I spoke about has a huge required component for care coordination. Does that help?
It does. So is the distinction between SMI and SED the age?
Yes, ma'am.
If it's under 18, it's SED. If it's over 18, it's SMI. Just because we don't diagnose people with SMIs until they're 18 or older. So it's a definitional issue here. Okay. All right. Yes. Thank you. And I think Madam Chair was going to let me go back in time and ask Dr. Brensel a quick question.
Yes.
And I thank you very much, Madam Chair. Dr. Brensel, thank you so much for your presentation. And the slide with the recommendations was so helpful, so concise, and just, that I hope that we'll all take that to heart when we get to the final stage of our work as a task group. You mentioned specifically the revolving door, reducing that issue, and Representative Fleming was also asking about that, and improving outpatient follow-up. And so I really want to tie that back into the Tim's Law question and Commissioner Morris's first presentation. We know we're going to have Jefferson County covered. We're going to have Western Kentucky covered eventually. Are there any areas of the state that the current grant, that the current funding would leave out for the Tim's Law implementation?
I'm going to defer to Commissioner Morris and that she's been more directly involved. I think what you heard her say is that part of this is very deliberate, and we intend to try to understand what it takes to do this and what are the upfront costs, and then how long before you realize a return on investment, and can we rebalance dollars? I mean, if we're going to have savings, we got to figure out where and how to move it. But I'll let Commissioner Morris talk about that.
Yeah, thank you for the question. So on slide 3, there's a map that shows where we are definitely going to be, which is the purple and the green, where we hope to be, which is the yellow. The rest of the map, which is a light blue, will not get any services under this grant. The money's not going to stretch that far. So right now, I would say we feel pretty optimistic we're going to be able to stretch it to serve those yellow counties. The purple is all inclusive of the central state region. There's just 2 CMHCs that admit to that hospital. For Western State, all 4, the green and the yellow, all admit to the Western State Hospital. So definitely the green, hopefully the yellow. Just for your knowledge, that each of our 4 state designated hospitals take admissions from specific counties. So if your county is assigned to say Eastern State Hospital, it won't be touched by this particular grant. Does that answer your question, ma'am?
It does. So we would need to come up with, or you would need to come up with additional funding somehow in order to serve Senator Carr's district, or Eastern Kentucky or Northern Kentucky, as I understand it. Is that?
Yes, ma'am.
Thank you. Thank you.
You're welcome.
Thank you very much. We're going to go ahead with the rest of the agenda, and we're going to have to move a little more swift. At this point, we have 3 additional speakers, and I believe only one is here in person. Andrea Blake, would you come forward? I think due to time constraints also that we're going to have all 3 or 4 or 5 of you present to the task force, and we will take questions at the end of this presentation. In addition to Andre Blake, we have Jailer Terry Nunnally of Muhlenberg County Detention Center, Sheriff Will Ward, the Muhlenberg County Sheriff, and Deputy Chief of Police Shoemaker. Would you please proceed and identify yourself for the record? Please turn your mic on. It's right before you.
Here we go. So sorry.
Thank you.
So, again, my name is Andrea Blake, and I'm just here as a family member of a dual diagnosis of a severe mental illness and substance abuse.
Welcome. I'm so glad you're here.
Thank you. I've learned a lot, so I thank you for the opportunity. I am extremely intimidated. I do not have any knowledge that you all have. I don't have any experience except for this past year. But I do have a story to share, and I pray that in sharing my story, it can even help with the knowledge that you guys have.
Don't be intimidated. We all, just picture us all in long red underwear or whatever.
But I've taken the opportunity to read the previous minutes, and I'm so encouraged to just see that the issues that my family has personally faced is being hit head on by this committee. It brings me great relief. The things that we've have to endure, it's not that it's been impossible, but it's because my sister-in-laws who we're caring for, we are guardians of her now. But it's because she's had us on her side. Anybody that has had severe mental illness that's had to do the steps that I've had to take, I do not feel like we'd have the mental capacity to do it based on our situation. So I say that just by saying that a lot of the programs that I have seen be put into place are beautiful in theory, but the reality of it when it comes to everyday life hasn't worked so smooth for us personally. And so that's just the small part that I want to share. And so my sister-in-law has been admitted into Western State Hospital 14 times, Baptist Health Hospital Health Unit 5 times, and Lincoln Trail Behavioral Health Hospital once in only 6 years. So we are one of the revolving door cases. She has shown some intellectual disability through her schooling, through high school, and so there's really a fine line from us on what is her mental disability, intellectual disability, what is she's diagnosed schizophrenic, schizoaffective, and bipolar. So what is that? And then also what is from the substance abuse. So now that substance abuse isn't in the picture, we're able to at least narrow it down to those 2, but there's still a lot that we don't know go into what category with that. For many years, she would call us asking for help, and we would tell her we were willing to help her but not enable her. So help meant full rehabilitation, putting commitment into getting better and things like that. And that's not the type of care that she wanted. And so because of our answer and her life choices, we really grew apart. Throughout the years after that, we really saw her decline, and especially in the past 2 years that it's been very difficult for her. So in January, my husband and I were talking about this, and we decided that we probably need to figure out what was going on, because like I said, there was a big distance in our lives, and so we really didn't have an idea what was going on. We just knew she'd get arrested, she'd go to Western State, and she'd be right back out in either 72 hours or 21 days. So we're very thankful for Chief Harvey and the Greenville Police Department and all that they did. He took the time to sit down with us. He explained to us the mental health care process. Again, we had no knowledge of it. We thought she was getting the care that she needed. But after sitting down with him, and this is probably not the correct terminology, but we have phrased it this way. So what she was getting was what we call phase 1. She would go to Western State. She would stay there until she was no longer suicidal or homicidal, and then she would be released. That is not an appropriate treatment. She learned to say what she needed to say in order to get out, and then she would go right back home to nobody. She lived by herself, so nobody to help her, nobody to continue the care with her and things along that line. And so he helped us to understand that there is another phase, which is what the Lincoln Trail Behavioral Health Hospital is. It's located in Radcliffe, Kentucky. It was a 14-day program, and so that still wasn't very long for us, and we were scared in that. But they reassured us that they would not discharge her until she was stable. So her 14-day program turned into a 4-month program, and so we were very grateful for that. But when we spoke with Chief Harvey, it was also at that time he recommended guardianship over her. And so that's how we were even able to get her into Lincoln Trail Behavioral Hospital. We didn't understand guardianship. I mean, she's schizophrenic and on a drug abuse. So, if us as a family take guardianship of her and she murders someone, are we responsible? And so we had to do some digging in on things like that to really figure out the process as well. But as we went through all of that, again, the Muhlenberg County, we cannot sing their praises enough. Once he sat down and talked to us, we went and got the paperwork. We filled out the paperwork that night. We returned it the next morning, and by that afternoon, we had emergency guardianship. So we were able to move quickly because they understood what she needed, and they were willing to make those steps for her. And so we always want to give them the praise that they deserve, because without them, our family wouldn't be in the position that we're in at this point either. And so where our problems really start is once so we get the guardianship, and then before we could find her, she gets arrested again. And so that delayed us getting her into the Lincoln Trails for a little bit, but it did give us an opportunity then to speak to her court-appointed attorney. And so again, because they understood that obviously she's a criminal. We do not want to undermine anything that she's done, but they also knew that she did not have the mental capacity to even understand what she was doing at that time. And so they agreed to defer her charges for 2 years, allowing us to focus on that. And we had just made an agreement with them that we would constantly stay in contact with her. And if we felt like after the mental health care came into effect that things needed to be done, that we would make sure that they would do that, and they've been very gracious with us in that. So we're waiting outside of the jail for her to get discharged. I'm calling Lincoln Trails, making sure they have a bed available, and I have called them probably 10 times in this 2-week period, making sure everything was lined up. And so at this point, it's the very first time they mention, she has to wait 24 hours after getting out of jail before the insurance will pay. And so I'm in a panic because what do we do with her for 24 hours? And so I have a 7-year-old daughter, so her coming home with us was not an option at that time. And so we thought, we'll call the local Pennyroyal Center and see what help we can get there. Maybe they'll do an evaluation, put her in Western State for the 24 hours, let us pick her up there. We called Pennyroyal. They told us she did not have insurance and they would not even see her. And so we're in the parking lot trying to figure out what to do. And thankfully, at that point, Vicki Harvey, that is an employee at the detention center, she realized what was going on, and it all had to do with the insurance. And again, this is not my specialty, but I guess once an inmate gets incarcerated, their insurance gets canceled for the time period that they're in, and then it gets reinstated once they get out. But because the jail and detention center were familiar with this case, they learned that she did not need her insurance canceled ever. And so once we realized that was a problem, we were able to take her to Lincoln Trails right away. But I have been told that you don't get turned down for mental health because of insurance because of no insurance is why I wanted to mention that, because in reality it did happen. After she was in Lincoln Trails again, she was there for a 4-month period, and we were told whenever we got her admitted in that she would be assigned an ACT team, and that when it came close to discharge, we would be contacted 3 days prior by this ACT team, and that we would meet with them about what our next steps would be. While she was there, it was during the COVID restrictions of this year, so we weren't able to visit her, so we really had no idea. I mean, we could call as much as we wanted, and I called several times a week. She would either pick up the phone and hang up on me, or she would ask me for cigarettes. So if it was a need, she would talk. Otherwise, I wasn't even getting to talk to her. And so it came time, and they, towards the end of it, and they told me that they were having a hard time finding her a place to go, and asked if I could join them in trying to locate that. And so I welcomed that with them, and just kind of talked to them about what are we even looking for. I don't even know where I'm calling, but yeah, I'll come on board. And so they mentioned then the personal care home. They had tried to get her submitted in. Well, I have to backtrack a little bit, sorry. So she ran out of insurance days. She had Medicare A and B, and she ran out of the maximum days of that, and so we had to apply for Medicaid. But instead of getting a full Medicaid, she got a QMB service, which cut off some of the treatment plans. And so they were hoping to do a shock treatment plan with her, but we're not allowed to do that. But I don't know if it's because of the insurance or whatever reason of that. And so then that's when they started looking for a place to live. And like I said in the beginning, they had told us that we would have a 3-day period to meet with them and talk about the thing. But I ended up getting a phone call saying that she's getting out the next day. And I'm like, well, wait, this isn't following your protocol, for one. I've not been contacted by the ACT team. I have no idea how she is mentally. What are you telling me? This is not happening tomorrow. And it wasn't until I mentioned the protocol that they were willing to keep her another 3 days. And so that worked. And the discharge nurse that I was talking to, we came up, she was making phone calls and I was making phone calls. I don't know if we called any of the same places or not, but between the two of us, we made 52 phone calls in the entire state, and only one facility was willing to take her. And so we are thankful for that one facility, because we hadn't seen her in 4 months. When we dropped her off, she seemed demon-possessed at that point. And so not knowing if she still was or not was scary again to bring her home with our daughter being there. But even at that point, I've still never heard from the ACT team. I never I did talk to the discharge nurse or the discharge doctor. All I got told at that point is that she's stable. I asked, what does that mean? And they're like, well, she's as good as we can get her. And I'm like, I still don't know what that means. And so we were thankful for the facility to be able to take her in. And we picked her up and drove her there that same night. It was also during this time of speaking with the discharge nurse that we were told maybe we shouldn't do the guardianship of her, and that we should let the state have guardianship over, because if the state had guardianship over her, someplace would have to take her. And so it wouldn't be such a trial between us for that to happen. And then when I finally ended up telling her, another option she gave us was just to let her be homeless. And that did not sit well with me. And I just told her right away, she said it happens all the time. And I just explained, I'm sorry that it happens all the time. It breaks my heart that it does. But if it's somebody that's in my family, it won't at all cost. And so it was then that she realized, we're really serious about making sure she's in the right care and stuff. And so at this time, we really had to start praying about what was best for her, because we're very ignorant to all of this. Like, we have zero knowledge at all. And I mean, thankfully, things are falling into place as we need them to be, but we are just not educated in it. And so at the time that we were praying, do we need to stay guardian? Like, is that really what's best for her, or do we need to give that? I'm very thankful, and he's joining here with me today. Jonathan Rouse from the Kentucky Guardian Association reached out to me. I had joined that, trying to learn about schizophrenia, trying to learn about what guardianship would look like for us. And I had sent an email in, and he reached out and called me and just explained the whole process of it all. And so just by being educated by that showed me, like, we need to fight for her the best that we can. And so from him sharing his knowledge with me, I was able to move forward. And then we decided to continue in as her care. When she entered into the personal care home, they provide 3 meals a day, medicine management, and then they have outsources that come in. There's an organization called Hope and Healing in Madisonville, Kentucky. They pick up patients from the personal care home 3 days a week. They do personal care training with them. They have group therapy, individual session, life skills. So she's like learning to cook again and all that. So we had all that in place for her. And she was doing very, very well. Like, I have been in this family, my husband and I have been married almost 9 years, and I've never known her to be as well as she was doing. And so we were so proud of her and just so thankful for all the work that was being done in her. The negative to a personal care home that we were in, and this is another thing I don't understand. I guess some personal care homes can lock the doors and other ones cannot. And so this was a particular one that they could not lock the door, so the residents were able to come in and out however they wanted, which also meant they could go and do whatever they wanted with no accountability. So my sister-in-law is doing well mentally, but she still does not have the correct mind frame to say yes or no to things that are not good for her. And so she was presented with an opportunity to participate in substance abuse again, and took a downward spiral through that. But it was at that time that my husband and I realized if she's in a good, loving environment where that's not an option for her, we've seen her thrive, we can see her come back and thrive again. So we decided then to move her in with us. So in the end of June, she began living with us. I tried to move her care from Hopkins County to Muhlenberg County, where we live. I called the local office again, explained the programs that she's been involved in, asked what they had as options to see if we could get her transferred. And I was told they had no idea what I was even talking about. And so I don't know the appropriate lingo. I don't know if I asked for the wrong things or any of that. But so we've had to keep her where she is. It's a 35-minute drive, so I was having to take her 3 times a week, 35 minutes there, either stay in town or come back home and go pick her up 3 hours later. And it was then that the psychiatrist at that organization told us that there was another program that I could apply for, which was a community integrative service, and then that would provide PACs with her. Okay, so need to back up a little bit more. Also, when she moved in with us, our first concern was her psychiatric care, but in order to get that, I was told we had to have a referral. So I took her to a nurse practitioner for a primary care. She had not ever really taken care of herself as far as annual visits for her health and her dental and vision and all that. So we wanted to start a fresh slate with that. So we went to schedule an appointment with a nurse practitioner. I explained at that point we're looking for an annual physical, make sure her health's in check, see what any other issues we need to address. But really what's most important is we need that psychiatric referral. And so the appointment was made. We went to it the following week. I walk in and I get told that the appointment has been canceled. So I start to question because I knew I hadn't canceled it, and so I didn't understand why it was canceled. And it was at that point I was told that the nurse practitioner said her case was too severe for her to take. I was very angry and very hurt and crushed. And I just looked at the receptionist and I said, nobody deserves to be treated this way. Like, you could have called and told me this over the phone and I would have understood 100%. And I'm like, but for you to say this, not just to me, but she's having to listen to it. And there's people back behind us in the waiting room that just heard what you said as well. And I was like, you know, the only way people are going to get better is if people believe that they can get better and are willing to fight for them on their team. So though I understood the background to it, I don't understand the way that it was handled. And so eventually we were able to get with a very good nurse practitioner for the family care, and all that was done. We still do not have a referral. It's now 3 months later, and the first referral was sent to Baptist Health in Madisonville, which is only an inpatient care. They don't have any outpatient care. But at Hope and Healing, where she's doing the group therapies, they are in connection with a psychiatrist there. So we have done 2 televisits with her. But even just last week, you know, we want to know what our expectations can be. You know, like, I hope that tomorrow I'm a better person than I am today. And then I hope every day that I improve. And I have that same hope for her. I don't feel like she's a lost case at all. And the nurse practitioner that we were talking to basically told me she was good enough because she's taking a bath and she's keeping a clean room. And so I don't feel like my family's on the same page with her, that's where we'll stay. And so that's something that we're still having to pray about as well. But that, you know, those are just some of the challenges. And so there's just one more. The last thing was last month we did our medicine refill. One of the prescriptions had to have a prior authorization. The prior authorization took over 10 days to get. Somebody that's on a psychiatric medication does not need to wait 10 days to get a medicine. It was a psychotic, it was one of her psychotic medicines, and so we were able to pay for it out of pocket, thankfully, so that she didn't have to miss any. But she's also on a fixed income, so even that was a big hit for her in that case. But, you know, luckily she's living with us, so she doesn't really have a lot of other expenses. But, you know, in a different situation, it could have been a lot worse. And so, anyway, as you can see, Dr. Schuscher has highlighted several things about the revolving door and the unavailability of housing, the lack of the medical care, and the need for medicine formulary is all real in our situation. Mr. Mark Kelly, he addressed the shortage of mental health professionals, and it's very terrifying when you need that medication. Like, it's not like you could go a few days without some of that. It could be detrimental. To fight, he also talked about the stigma. So to fight the stigma behind it, it's not even for me, it's not even the community that we live in, but even our doctors need to fight against that and provide better care and personalization because they need to be treated just like everybody else does. Dr. Alvarado, or Senator Alvarado, he repeated Dr. Schusser's concerns on the homelessness. But, you know, as you can see in our story, it's not always the case. You know, when we were trying our hardest to find a place for her, and we just couldn't find one that would say yes, and we had to take the one that was available. And then also, you know, people aren't willing to take the hard cases. That was the main thing behind of us. You know, I've not shared details of her story, and I'm very happily will with any questions that you all have to give you good examples of it. But I just wanted to use my time on what was, you know, being faced upon this time. And then, you know, again, the last one was, you know, people say that you should not be turned down for it, but when we approached that, we were turned down. And so, you know, whether we have medical insurance or not, I mean, mental health is not a joke that you want to mess with, and it not only can be detrimental for the individual, but also the community and the people that they are around them. And so in my conclusion, I just wanted to say that I agree. Dr. McCarran, I think was his name, he mentioned that education is the answer. And as you can see, I got educated along the way, every single step, by those that are in the trenches. And through that education, we've really been able to help her. But I do think that should be a way that all of it streamlines together. And so, you know, like one phone call shouldn't lead to 5 others. And, you know, one police officer should not have to stay with an individual for several hours that's already been in mental health hospitals. multiple times. I mean, it should just be an automatic, smooth process for them to get there and get the treatment. And then even today, it was mentioned, you know, that early intervention is important, but even when they're in psychotic episode, having to wait in a jail cell and allowing you the opportunity to bang your head back against the wall isn't helpful for the patients as they're in that state as well. And so I just want to thank you for your time and for hearing my story. And again, I am open to questions. I am open to sharing anything in personal detail that you want to know that may be able to answer some of the issues that have even been brought up today.
Thank you. Thank you so much. Your sister-in-law is very lucky to have you as her advocate. And if you'd stay at the table just a few more minutes, if you have time, there's some water for you. And we have Jailer Nunley. If you would also introduce yourself and proceed.
Yes, ma'am. Yes, madam.
We see you.
And you hear me now?
Yes.
I was a little computer difficulty. My name is Terry Nunley. I'm the jailer of Muhlenberg County Detention Center. I have been in law enforcement before I was blessed to become jailer for many years. And I've witnessed a lot of stories like Ms. Blake has given you today. As you know, when people are incarcerated, a lot of times they're incarcerated for a number of reasons. A lot of those reasons, I believe, is because of their mental illness. A lot of people act out, do things they shouldn't do because of their illness. When someone is incarcerated that has a mental illness, it's kind of an eye-opener for us because, as Ms. Blake said, we're not trained to be able to deal with someone who has a mental illness. We do have 24-hour nursing here, but as you all know, a nurse without being specialized in training for people with mental illness, it's also a challenge for them. So I'm very familiar with Ms. Blake's story. It's heartbreaking, but it's also inspiring because of the way she went about doing it and the hard work that her and her family has done. And kudos to you, ma'am. We get people in here on a daily basis that has some type of mental illness. Some of us drug psychosis, but as you all know, it doesn't matter how they get there. It's still a mental illness. And a lot of times when people become incarcerated, they get here and they got a mental illness. Sometimes they reach out, as she was saying, some of them sit and beat their heads in the jail cell. Some of them scream out. And to me, that's a scream for help. And it's heartbreaking to us because we're kind of limited on what we can do. We have the nursing staff to get involved, and we reach out to Penny Roll, they triage them. They do an interview through a Skype, so they can do a person interview over the computer. But to me, and this is my opinion, that system is not real well. And the reason why is, as Ms. Blake said, they can kind of condition themselves to do the answers that they want to give to be able to pass the evaluation. I think it needs to be a different avenue, more avenues for people when they're incarcerated to get the help that they need. And I think the system is it is broken. It's an old system we used in the past. Things have changed, times have changed, and we're making criminals out of people with mental illness. And to me, it's a shame. You know, I feel like there's other ways that we can make it better for everybody by working together. It's always a communication barrier when you're dealing with things such as this. And I think we need to communicate more. I think we need to have more discussions such as this. And I think getting together and doing this will open up doors, hopefully, and make our job easier, make law enforcement's job easier. And Ms. Blake, people like herself that's going through these things won't have to go through it in such a manner. So that's kind of where I stand. I'll make it brief. I know time's running out, and Chief Deputy Shoemaker wants to kind of elaborate on some of the things I talked about also. So thank you for your time.
Thank you very much. Is Sheriff Ward also there?
Unfortunately, Sheriff Ward is under the weather and
okay,
not able to make
your
it today.
Deputy Shoemaker.
Yes, ma'am.
Thank you.
Yes, ma'am. I am Chief Deputy Wade Shoemaker. I am obviously the Chief Deputy of Muhlenberg County. Real quick about myself, I've been in law enforcement for over 30 years. but I've only been with the Sheriff's Department as the Chief Deputy for the last 11 months. Next month will be a year. Didn't take me long to realize how busy the Sheriff's Department is, and especially how busy we are dealing with the mentally ill. I just want to share something and echo what Jailer Nunley said about we're making criminals out of the mentally ill. And unfortunately, in my opinion, a lot of times we are, and a lot of times law enforcement, especially the Sheriff's Department, is involved with the mentally ill, and I'm not so sure we should be a lot of the times. We are located within Penny Royal Mental Health Services District, and I will say that I had a meeting, Sheriff Ward and I both met with the area supervisor, Audra Hall, a few weeks ago and had a fantastic meeting. She was great. I think we all realized and all agreed that there was some issues in the system that need to be addressed, and I'm thankful for this opportunity to address them here. And I'm glad there's some dialogue being talked about to try to improve the system. I think the system has been in place for so long, it's basically accepted as that's just the way it is. But I think times have changed, like Jailer Nunley has said, and it's time to address it. Our calls are at an all-time high. Our calls for dealing with the mentally ill are at an all-time high. Real quick on our protocol, basically on dealing with the mentally ill, if the judge signs a mentally ill warrant, we'll come down to our office. We'll send deputies out to take that person into custody and take them to Penny Royal. Penny Royal has a satellite office here in Greenville. If it's during business hours, we'll take that person to Penny Royal, and they'll either do an evaluation in person or more than likely it's a Skype interview. If it's after hours, we'll take them to the local police department, either Greenville or Central City, for that Skype interview. Unfortunately, that evaluation process for different reasons takes a while. It's a minimum of a couple hours. I have some recent examples that we have done even today, and as of last week, is some examples I'll talk about, but those evaluation processes take a while. Like I said, a couple hours, and depending on the results of those evaluations, we're tasked with the responsibility of transporting them to Western State Hospital. Or an example I'll give that just happened last week, we had a voluntary walk-in that walked into the Penny Royal Clinic in Greenville seeking help. Turned into be an involuntary hospitalization. The judge signed an order, and the transport order was for us to take him to Baptist Health in Madisonville. The deputy first received the call. It was about 3:03 in the afternoon, and he didn't leave there until 9:23 in the evening. So he spent over 6 hours over there, and the next day we had to send another deputy over there to transport that same individual to Western State. We had an incident that occurred a few weeks ago. There was a lady there, the intensive care unit at the Muhlenberg County Hospital. They had called and said they had a transport order for us to transport her to Western State. When I first walked in, I was the only deputy available at that time. So I walked in there, and I'm not going to say panicked, but she had a very concerned look on her face and was very apprehensive of seeing me walk in. She thought she was going to Western State, and in fact she was, but she was very agitated that I walked in, basically, in law enforcement and not somebody else. So there's sometimes when dealing with the mentally ill that I think we could escalate the situation just by people's views of the police. And sometimes, again, that I'm not so sure law enforcement should be involved in all the mental ill cases. Again, I mean, first and foremost, we want to see these people get the help we need or they need. And I just want to, from the Sheriff's Department, I think just the length of times that our deputies are tied up with them, it's excessive. And we had a recent in-service in Madisonville. There was a lieutenant there from Jessamine County Sheriff's Department. He was, we were explaining how we dealt with mentally ill, and he was saying that Eastern State Hospital, that's in our district. And he says, all they need is a citation or a mentally ill warrant. They'll take them there and drop them off. I would love to see us get there at some point where we could just take them, even if it's Western State, transport them down there and drop them off. They get the help they need mentally. If there's a problem with them physically acting up, they have people on hand to deal with them physically. So that's where I hope to get. I mean, we're not there yet. And Penny Royal Audra, like I said, Audra Hall has been fantastic to deal with. She's aware of the problems, and we're both taking steps forward. We're not where we want to be yet, but we hope to get there. We hope to get there soon. Thank you.
Thank you so much for your insight. If you all could stay, we're going to have some questions, and we're about over our time limit, but I think we've got really patient people on this committee, and if they don't have to go, they'll stay. Some have to go, possibly. Representative Co-Chairman Bentley, I believe you would like to comment or speak. Co-Chair Bentley.
Thank you. Thank you, Senator Kerr. Can you hear me?
Yes.
Okay. I just wanted to make a short comment, and that is we had talked about the mobile mental health on wheels before, and with this 15 million going to 20 states, the mobile crisis intervention that Ms. Hoffman spoke about, I want to give people the site to go and read about that. It's cms.gov newsroom, cms.gov newsroom. So the ideas that we've had in this on that mobile unit to help people may be combined with that. And so, that mobile mental health unit since May of 21 saw over 220 individuals who would not go into the building because of the stigma of their cases. So I just wanted to bring that up, and we'll discuss it more later. And thank you, Chairman Kerr, for being considerate to let me say that.
Thank you very much. And again, are there any questions? I'm so thankful that Representative Prunty has seen and made sure that these people got to testify from Muhlenberg County today. And I really thank you. Yes, please do.
I just want to thank you all. I know I felt like this put a face, a real live case to what we've been hearing. And it just, everywhere I went, I would hear from law enforcement, I'd hear from the jailer that we really need to address these issues. So I thought it was important to get these voices heard, and I appreciate you. I'm so proud of you for your testimony. You've done an excellent job, been very professional, and thank you, gentlemen, for being so patient at home. And thank you, Madam Chair, for having me here.
We appreciate all of you testifying, and as Representative said, a picture is worth 1,000 words, and that could never be more true than today. So thank you, Andrea, for being here, and you did a marvelous job.
Thank you.
I'm going to now announce that our next meeting will be, and if you all would like to come back, you're welcome. It would be October 19th at 3 p.m. And at this time, I would take a motion for adjournment. We are adjourned.
So moved.